Thanks everyone for joining us for the second webinar of our Spotlight series on patient-reported measures. My name's Sarah Ely and I'm the Senior Project Officer Capacity Building at Health Translation SA. And I'm your host for this 4 series, which there's another 3, including today, and another 3 weeks. I'm going to start by acknowledging that the Kaurna people are the traditional custodians of the Adelaide region, which my feet are on. And I recognise their cultural, spiritual, physical and emotional connection to the land. I honour and pay my respects to Kaurna elders past, present and to the future. And I know my feet are on Kaurna lands, but Belinda and Nik, you're not going to be. So if anyone else would like to pop in the chat where you're zooming in from, please feel free to do so. So the Spotlight series is an initiative launched by Health Translation SA in November 2021, and it's a way of building knowledge and capacity in a range of essential research, translation skills and topics which may not be well understood. And so we do this through a month-long focused education initiative. We run 4 online webinars and we also dedicate our socials to sharing relevant information on the topic. We've run a few now in the areas of implementation science, research impact, community engagement, BMRFF, and health economics. And all of these previous webinars can be accessed on our website. But for this current series on patient-reported measures, we're pleased to be co-hosting it with the Commission on Excellence and Innovation in Health. And they are the lead agency for innovation in healthcare in South Australia, bringing consumers, clinicians and other collaborators together to turn ideas into better healthcare. So if you'd like to know more about what they do, I encourage you to visit their website, and they've been instrumental in helping us to pull this series together. And I just want to briefly, for those of you who are unsure who are Health Translation SA, we're an NHMRC accredited research translation centre. And we offer a collaborative cross-sectorial approach to research and enabling translation of findings into improved patient care. So that means we seek to connect health researchers and the health services with the right stakeholders and the partners to accelerate the implementation of research discoveries. And we have 11 partners, academic research and healthcare agencies, which you can see down the bottom of this slide, which encompasses the breadth of healthcare service delivery across South Australia. And our vision is to accelerate the translation of research findings to improve the health of South Australians. So we work with partners and stakeholders as an independent catalyst and broker to mobilise collaborations. We do this through a variety of ways, which you can see on this diagram, but the Spotlight series falls under education and training. So today's Spotlight series webinar, we've got 2 excellent speakers. We've got Professor Belinda Gabbe and Adjunct Professor Nik Zeps. Both are from different areas within Monash. Belinda's going to present first for 20 minutes, allowing 5 to 10 minutes for questions, and then we'll go on to Nik, who will present with questions for him at the end. So Belinda, she is the head of Pre-Hospital Emergency and Trauma Research Unit in the School of Public Health and Preventative Medicine at Monash University. She's also an NHMRC Leadership Fellow. She holds an honorary professorial appointment in the Health Data Research UK Institute at Swansea University. And her research focuses on evaluating trauma care, trauma systems research, and improving understanding of how well people recover from injuries and how we can measure the burden of injury. So I'm going to stop sharing now. If you'd like to take over, Belinda.
Thanks so much, Sarah, and thanks for the opportunity to talk. And I'll acknowledge the traditional owners and the lands on which I'm standing today, which is the Wurundjeri people of the Kulin Nations, and give my respects to their elders past, present and emerging, and extend that acknowledgement to anybody of Aboriginal Torres Strait Islander peoples who are joining us today. I'm going to try and share my screen and hope for the best that this all works smoothly, which it did just moments ago. So here we go. And just get us into slideshow mode. There we go.
Thanks.
Is that all working, Sarah?
Yeah. Perfect. Thank you.
So Sarah's asked me to talk about the experience that we have. I run a group called VStorm, which is the Victorian State Trauma Outcomes Registry and Monitoring Group. And under VStorm, I run a number of trauma registries. And the reason that we have PROMs is pretty much in our registries, and we do it routinely, is because most of our patients who sustain even quite serious injuries and make it to hospital actually survive their injuries with the risk of long-term disability and problems related to their injuries. And historically, trauma research is focused on survival only, and what we've been trying to do is shift that focus to really looking at the quality of the survival of the patients and how well they recover. So the reason that we go about this is because we don't have a lot of information around non-fatal injury burden. So we really don't understand who recovers when and how well across the world, and how that differs according to how we design trauma systems, how that differs according to socioeconomic status, how that differs across with cultural differences. So we decided to tackle that by collecting PROMs within our own trauma registry. One of the other things that we were really interested in doing, as well as the ability to benchmark outcomes between trauma services, and also to provide information around how well people recover so that we can guide investment and the design of post-discharge health and disability services. And I might, if we get time, I'll talk about one of those elements today as well. So just a little about the Victorian State Trauma Registry, which a lot of this would hold for our Victorian Orthopaedic Trauma Outcomes Registry as well. But our Victorian State Trauma Registry has really been operating since July 2001. We have a population-based trauma registry. So every major trauma patient in Victoria who meet the criteria are included on the registry, irrespective of which hospital they receive their care in. And there's 138 trauma receiving hospitals in the state, of which 3 are deemed major trauma services, 2 of them adult and 1 of them paediatric. We include people on the registry using an opt-out approach. So they receive a letter and a brochure that explains their inclusion on the registry, what we collect about them, how we use that data, and how to opt out if they wish to do so. And the registry runs independent of health services and government. It's co-funded by the Transport Accident Commission, our third-party road trauma insurer in Victoria, and also the State Department of Health. The custodians of the registry data are a representative steering committee, which includes representatives from health services, ambulance, from Monash University, from the funders. We have a consumer representative, and we have other representatives as well on that representative steering committee. We used to, when we first started the registry, we were looking at about 1,500 major trauma patients per year. We are now well over 4,000 major trauma patients per year in Victoria. And the registry was really set up to monitor the performance of the state's trauma system. The registry collects information from the ambulance services that look after the patients. It collects information from referral hospitals. So, for example, if a person is injured in a car crash and taken to a regional hospital and then transferred to one of the major trauma services, we would get information from the ambulance, from the regional hospital, and also from the major trauma services. We also collect data from retrieval services who organise the inter-hospital transfers. We collect a lot of information from the definitive hospital, where the patient goes at the end of that stay. And we've been collecting post-discharge outcomes since 2005, but in a very structured and consistent way since 2007. So what we collect from our patient-reported outcomes really is we've actually made changes over the time, because it's been a long time that we've been doing this, and instruments that we chose way back when have changed out because new and better ones have been made available, or we've been able to make some modifications. So in our adult patients, we collect the 12-item HUDAS, the WHO's Disability Assessment Schedule, and we switched that in and switched out the SF12 instrument in January 2016. We collect the 5-level EQ5D now, which is a health status measure. We previously collected the 3-level version, but as the 5-level became available, we changed over to that one. We collect the extended Glasgow Outcome Scale, which is a global outcome assessment of disability. We collect a numerical rating scale for pain. We also collect information about return to work and work disability questions, and some questions about self-reported disability as well. For children, we collect the King's Outcome Scale for closed head injury, called the COSHI, which is actually very similar to the GOES. And I'll mention any of these, but please ask any questions if you really want some information around the actual instruments themselves. And we used to collect the Pediatric Quality of Life Inventory, which was a health-related quality of life tool for PEDS. But we changed that over to the youth version of the EQ5D. And the reason we did that is because we're increasingly following patients up over time, and we needed some consistency in our instruments across time. And we were finding that sort of adolescent, that switch between what was considered a pediatric patient and what was considered an adult patient in the trauma system was causing us some issues with the continuity and the collection of outcomes. And aside from that, we also do some fairly extensive data linkages as well, but I'll focus here on the PROMs. So how we go about this is we have a centralised call centre, and that services the clinical quality registries that we hold here, and also does quite a lot of follow-up of clinical trial participants as well. So we try to coordinate as best we can across our registries and across our trials to minimise the number of contacts that patients and participants actually get. So we really try to make it a bit more streamlined, and we also really try to coordinate the outcome instruments that we're collecting across clinical trials and registries as well to make it much nicer for the patient's experience. We use trained follow-up staff, and we have two staff who supervise and train all of the staff. We use call monitoring, so we have a call monitoring system so that we can so that the supervisors can listen to the calls and then see if there are any issues or anything that needs to be followed up, and also just to help with ongoing training of staff. And we do not keep those recorded calls. They actually do get deleted after a brief period of time. We use TIS, which is a translation service for patients who are culturally and linguistically diverse. So if they would prefer the interview done in a specific language, we can arrange a TIS interview for that to happen. And we actually pay for that service to use TIS for our clinical registry patients. And as part of this, we've developed a very extensive distress patient protocol over the last sort of 15 years. And a lot of a very detailed list of services and contacts to support for patients if they ask, or if it comes up in the interview, so that we can actually provide something back to our participants. And then since early 2020, we've actually been providing an option for online follow-up of patients as well, so that they can actually choose to either do their follow-up by telephone or they can do their follow-up online. And if they choose for online, we just get their email address, send the link to that, and they can complete the instruments online. And we've actually just published a paper, which I think just came out at the start of late last year, actually, I think, which was really looking at what the difference was between people who do the telephone interview and who opt for online completion. And in our major trauma patient population, the uptake of the online version was about 50% of patients, but the completion rate is actually lower. So when you give patients the option to complete online, they actually do, the follow-up rate is actually a little bit lower, so 77% versus the people who opted for telephone was 89%. And once they do start, they actually do complete, which is fantastic. So our completion rates for the EQ5D were the same for both. But we had some challenges with the HUDAS, and mostly because we were rolling this out during COVID when Victoria was in very significant lockdowns. And there's a question on the HUDAS, which is around learning a new task. And any Victorian at the time could do nothing and go nowhere. So they were all choosing not applicable for that, which meant you couldn't actually calculate a total HUDAS score. So we did learn a lesson through that process, but it was just a situational issue, and it's since been rectified. And what we've really been happy with about the offering the online version is that we do see, a specific group of people taking up online, particularly of younger age and higher socioeconomic status, which you would expect. But we also saw that the patients whose preferred language was other than English actually were more likely to pick up the online option. So we're wondering if we're actually giving people who speak a language other than English better options for follow-up than we previously did. So that's really kind of how we do it and what we do. And that call centre, I think, does about, at last estimate, around 5,000 calls a month. So it's a pretty big endeavour to sort of run a complete call centre. And we do go through a lot of sort of management things about trying to manage noise and staffing and all those types of things, but they're pretty effective at what they do, and our follow-up rates are actually really excellent. So how we use the data in Victoria. So there's been a lot of things that we've used the data before, and a lot of what we've been able to do in Victoria has been the first time it's been done in the world. So we've been able to answer some of those sort of answer those hypotheses or those questions that have been out there. And what we were able to show was that we reorganised our trauma system so that we made sure that our major trauma patients come through to these one-stop shops for trauma, the major trauma services. And we were able to show very early that there was a survival benefit from doing that. So that restructure of the trauma system actually increased the odds of survival for patients. But what we were able to do with our PROMs work was actually show that not only were they more likely to survive, but they actually had they had a higher odds of better functional outcome as well if they were managed at those major trauma services. So that's been a really positive outcome for the design of the trauma system. We've also been able to use the long-term outcomes that we've done, and particularly the EQ5D, to generate disability weights for looking at disability-adjusted life years and looking at costing, what the impact of the trauma system has actually been. And what we've been able to show over time is that the cost per case has actually gone down. So we're seeing some significant improvements in our patient population over time. So we've been able to use our PROMs for that. We've also been able to take the PROMs work that we've done within the clinical quality registries, within the trauma registries, and combine it with a large number of cohort studies from around the world that have been time-specific cohort studies, and pulled all of that information together and generate disability weights for burden of disease studies that are based on patient experience and actual patient outcomes. So most burden of disease studies use disability weights that are created by panels, and panels of people that have never actually had the condition of interest. And so we could actually use the EQ5D data and use the PROMs data to actually generate disability weights that reflect actual patient outcomes. And these have actually been picked up in the AIHW's Burden of Disease, the Australian Burden of Disease report as well, and been used to show the differences between the panel type ones and the ones based on actual patient outcomes. We've also been able to use it to dispel some common themes. So we always had there's always this theory in trauma that wherever you are at 12 months, you're not going to get any better than that. So that, all your recovery will occur in that first 12 months after injury. And after that, that's how you're going to be forever. And we were able to use the data that we collect out to 2 years to actually show that that's completely not the case. And that there was significant improvement from 12 months to 24 months after injury. So patients do take a long time, but there is improvement after that first 12 months. We've also been able to look and build this into a bigger study where we've been following patients up at 3, 4 and 5 years. So we take our registry 6 months, 1 year, 2 years, and then we're following them up at 3, 4 and 5 years to see what the change in outcomes were. And we actually saw improvement out to 3 years in this paper, which was published in PLOS Medicine. And we could also look at the factors about the population that actually were associated with whether patients did well or didn't do well, and really across all of those items of the EQ5D. We also could look at return to work. And so this was a paper led by Alex Colley from one of our studies, which was taking the PROMs data from the registry and looking at return to work at 4 years, up to 4 years. And this is actually a lasagna plot. So if you haven't seen these before, they're a little like river plots or alluvial plots, but the red is here at 6 months, the people who hadn't yet returned to work. The green is the people who have returned to work. And you can see by 12 months, some of the people who were working are no longer working, and some of the people who weren't working are actually working at 12 months. And you can see those splits all the way down the line. So that's actually been really informative, because people assume if you go back to work, you'll stay at work. But in reality, that's not the case, that people move in and out of working status over their recovery. And what we can do is understand the types of patients that move between those and then develop better. And it's being used to develop better return to work programs for people who are recovering from serious injury. So we can feed that directly back into those programs and help them understand that it isn't all a linear, you just go back to work or you don't go back to work or you never go back to work, is that people move between working and not working for different reasons over time. And one of the other things that we've been doing is using our PROMs work to actually benchmark outcomes across centres. And these are not trauma centres, these are rehabilitation centres. So this is just a single graph for severe traumatic brain injury, which almost exclusively goes to inpatient rehabilitation. And what we're able to show is that we have basically four centres in Victoria, that inpatient rehabilitation centres that manage severe traumatic brain injured patients. And what we actually found was that the functional outcomes and the return to work outcomes at one of the centres were profoundly lower than the other centres. And actually that centre no longer admits severe traumatic brain injured patients, and it's almost and a new centre has actually opened up, which has taken over the extra caseload. But we can actually show that there were differences. And if I showed you many of the graphs across rehabilitation for other patient groups, we have some very poorly performing rehabilitation centres, and we've been able to feed that back into government and into the Transport Accident Commission as well. So that's kind of how we've been using it. And aside from that, we've been using our PROMs to look at specific patient groups. For example, severe pelvic ring fractures, people who have limb-threatening injuries, being able to look at the differences in different types of approaches or management of different conditions or different injuries. And we've also been using it in studies where we've been trialling new methods or new allied health models of care that have been feeding into those analyses, feeding into those evaluations to determine optimal allied health staffing and models of care as well. And we've published a paper recently about that. And if anybody is interested, it was it was actually shown to be really highly cost effective to have early and intense rehabilitation in the hospital, in the major trauma centre for major trauma patients. And yeah, and that has definitely changed what is considered standard care now. So that's kind of what we've been doing with all the data. And I know it's been a bit of a cook's tour through how we do it and what we've been using it for. So I just sort of thought I would finish with what we're using it for in the future, or where we think we're going with it. And one of the things that we're looking at is, oops, sorry, I'll skip back a slide, is looking at getting the feedback into the trauma centres. So feedback directly to the trauma centres of the patients' longer term outcomes, to help them understand how well their patients recover compared to services at their level within the trauma system. And we're actually starting to build some Power BI platforms that will allow them to do that, allow us to do that benchmarking. We are ramping up our usage of data linkage to better understand our patient journey and outcomes. And one of the things that we're really pleased about is that we've got in principle support to actually link our registry with the national, the NDIS, so the National Disability Scheme. So we're actually going to link to that, because at this stage we actually don't know what proportion of our patients transfer or transition onto the NIIS or the NDIS. So we'll be able to learn that, and also greater linkage with rehabilitation across the country as well. And as I said, we're constantly feeding our data into clinical trials. So the PROMs data that we're doing is actually relieving the workload for a lot of clinical trials. So we give them our data, obviously with all the right ethics approvals and all the right sort of data sharing agreements, but we provide the information through to clinical trials that are using the outcomes that we're interested in our patients. But also using the PROMs to actually evaluate care models and health service changes as well. And we always make our data available for research, and always have done. And yeah, we sort of process about, 200 to 300 requests a year for data from the registry. So it's a pretty big operation. And just to finish, these are some of the quotes of the patients that have been followed up along the way, and our follow-up rates are actually really high. They're around 85–86% at 6 months, around the same at 12 months, sometimes a little bit higher, and around 80% at 2 years after injury. We actually have really good follow-up rates, and we're very proud of that. And often what we find is that we are the only contact that patients actually have. We're the only people calling to find out how they're doing. And it's really, really well received by the patients, which was something that we, when we were first asked to do this and we first put this through ethics, they were really cautious about, and they were really concerned that patients would not at all be engaged with this process. But we've actually found that they've been really highly engaged, and patients are very clear that, you know, that having that contact and having that follow-up has actually been very valuable for them. And just my contact details if you do need to contact me at all, and I'll finish there. And
Thanks, Belinda.
Yep.
Just lost my screen here, excuse me.
So we've had
thanks for that. We've made it in time for you to go off to your other chair, but does anyone have any questions? I really enjoyed that, and I liked hearing about the practical application and the changes that are resulting from this data that you've collected. I think especially that 12 to 24 months, I imagine that's adding lots of hope for people who are recovering. I just had a question around that. Have you found that that's changing how clinicians are working with any clinicians who are working in rehab? Are they working for longer with patients now, knowing that there's more likely to be a benefit, or has that changed anything?
It certainly changed the way we look at trauma as a whole patient population. So the perceptions, those perceptions, I think clinicians working with patients feel differently. They, you know, so if you're working one-on-one, and I'm a physiotherapist by background, you're working one-on-one with the patients, you can see the circumstances in the patients that you see of them improving. So when someone tells you that, oh no, patients don't improve after 12 months, you kind of go, actually, no, but I remember such and such and such and such and such and such. So this is actually putting it across the whole population, saying actually the individual clinician saying, yes, they do, when others are saying, no, they don't, is telling us actually they're correct, and that we really are in for the long haul in rehabilitating these patients. So, and it's actually been really important for the TAC to understand, because they were withdrawing services and not allowing services to continue at certain time points along the path, along patients' way. So we've been able to directly feed that back into the Transport Accident Commission so that they can have a look at their policies and make sure their policies are actually supporting ongoing recovery of patients.
Fabulous, thank you. Now, I don't think there's any other questions at this point. If there is, we've got about a minute or two to pop them in the chat. Yeah, okay, Belinda. Well, thank you for that, and we'll let you head off so that you can get to your next event where you're chairing. So we appreciate you being here today. Thank you.
Thanks so much. Bye.
So next we have Adjunct Professor Nik Zeps. Nik has a demonstrated track record of leadership in clinical trials, biomarker discovery research, medical ethics, and regulatory affairs. He's currently the Director of Research at Northern Health and the Director of Operations for the Prostate Cancer Outcomes Registries at Monash. He's an adjunct professor through the Eastern Health Clinical School of Monash and is clinical research lead for Monash Partners. So I'm going to stop sharing and I'll hand that over to you, Nik. Thank you.
Thanks. And if I'm a bit raspy, as I sort of alluded to before, it's due to the fact that I've got COVID. So I'm sorry about that, but at least I'm not infecting anyone there.
No.
Find my slides, so just bear with me 1 second while I organize that. We had it working before, not quite sure. Here it is. Excellent. I'll just pop it onto the view. So I think thankfully Belinda's given a really nice introduction, so I'm going to take a similar or extend on what she's been talking about, but talk about it from the Prostate Cancer Outcomes Registry perspective. And then talk a little bit about what it matters in the hospitals. But I wanted to set the scene a little bit by just alluding to the document that has gone out to public consultation, which I'm sure most of you would be aware of. The Framework for Australian Clinical Quality Registries is really the overarching guidance material for clinical quality registries. It's been a bit odd that a lot of the clinical quality registries, because they have been generated out of research organisations such as Monash, that they were written in some respects like a clinical research project. And so one of the things that Belinda and I had been working on together with our colleagues It was being led by Susanna Ahern, who was the person who's just awarded the 20 million by the Commonwealth Government for all the clinical quality registries, and within our school, and also with Di Brown. We've been looking at a pilot to integrate CQRs as clinical under the clinical governance rather than the research governance frameworks, and it's something that we really need to move to. And the reason I'm going to raise that right from the outset, because although there's a really important research activity, I know that there has been this sort of dichotomy, and I think it's a false dichotomy created, of saying that you've got clinical care on one side, then you've got research on the other side, and there's sort of two parallel activities, which is not what is stated, thankfully, in a document like this. And so I've just taken a couple of quotes out of it. But really, it's to say that the CQRs are fundamental to healthcare. They are the way that we benchmark activity. We actually learn about what we're doing, and we understand whether or not we're having a positive effect with our patients. Whether we're compliant with standards, whether we meet the standards and expectations that we've set through evidence generated by clinical trials and various studies. And so providing access to the information, as I say here, it's a driver of healthcare safety and quality improvement. It's a patient and consumer right, which is a really different way of framing this activity, as opposed to a group of interested clinicians and researchers who are doing stamp collecting and just like playing with data. I heard it once said to me, oh, well, you know, we want to make sure that, you know, those people who are using the data for secondary purposes are doing it for the best interest of the patients. And I was thinking to myself, what other reason is there to use the data? I don't know of any. Now, you could argue perhaps that we're doing some of it to benefit our careers because we like getting publications and grants, and that's the currency that we use. But I think that, unfortunately, that has sullied our ability to do some of this work. And I'm going to state why I think that's so important in terms of the patient-reported outcome measures. So it's not only the benchmarking of, you know, some very clear clinical standards that we have, and I'll talk a little bit about the prostate ones, but it really is, we know that standard 2 of the National Safety Quality Health Service standards is about engaging with consumers and making sure that we're serving their interests. So it strikes me as a little odd that we've created a framework that makes this harder to do. And when I inherited this, I've been working with Prostate Cancer Registry now for 3 years, but I only took over running it in February of this year. Is, you know, the surprising amount of work that has to go into just submitting ethics and governance forms for something that should be considered to be a routine care. Well, that's my soapbox rant over. So what I'm going to talk about next is really just about what is the prostate registry. It's actually a binational partnership, in contrast to what Belinda spoke about. And there are some national registries that are run as they're run centrally, and then like the stroke registry and the joint replacement registry, and then people send in information to them. PCOR started out a little bit differently in that it actually started in Victoria, out of Monash, and then grew, and other states and territories came on board, funded largely through Movember. And they are independent activities, but they abide by a common data set, and they didn't actually have, up until recently, and I helped write it, a standardized national protocol, which is essentially a statement of compliance with the national framework. But they have got standardized data dictionary and collection of data, and we work very closely together. We had a meeting of all the jurisdictions just yesterday. So we work together to achieve the purpose of a national, binational, in fact, because New Zealand's involved, clinical quality registry. But it isn't actually operating. I don't control Queensland, South Australia, or any of those, but we work closely with them. And this was an update we just put out jointly between Monash and Movember. Movember has invested enormous amount of money into this. We are closely involved with all of the state governments. with a large number of organisations, with the College of Pathologists, with the Urological Society of Australia and New Zealand. All of these are very important, but as are the consumer groups, and that's going to become relevant as I talk about that. We've actually, I don't celebrate this because there's nothing to celebrate about having so many people with a diagnosis of cancer, but we have now reached 100,000 people included in our registry. And this is just a snapshot saying this is all the states and territories, and we're just rolling out WA. They're the final group to come in. But you can see that whilst there's a nomenclature of PCOR TAS, PCOR VIS, VIC, sorry, there's PCCR in New South Wales and it's PCOC in South Australia. So there are some subtle differences. But overall, their intentions are assessing patterns of care, enabling benchmark reports of clinical quality indicators. So we tell people about, we feedback directly to doctors and to health services about how well their continence rates are, their impotence rates, all of their standard clinical indicators, their Gleason grades, how well they're using their MRIs for screening, all of those kinds of things. But also we do report the patient-reported outcome measures, and I'll talk a little bit about that. So the secondary function of the clinical quality registries for research, I'm just going to make a small correction to the idea of opt-out. We actually operate under a waiver of consent, but we give people the opportunity to opt out. Nevertheless, if they're included up until the time that they fill in the PROM, and then we give them an option to sign an additional consent at that time. We technically don't have a consent. And in most of the states and territories, the law says that opt-out is not a form of consent. It's not a legally recognized form of consent. So we actually have a legal waiver of consent granted by an ethics committee. And that is, in fact, the only reason we go to an ethics committee is because we need to get that waiver of consent. And as Belinda said as well, there's a capacity for linkage of registry data, and we had a meeting with your colleagues today at Peacock and David Roder and others about the pilot projects, which I don't have time to talk about today, but it's all very exciting about what we can do. So we take a very simple PROM, EPIC 26 short form. It's slightly expanded. It just talks about urinary function, bother, bowel function, and others. But how can we use this? And I'm in the interest of time, just because we don't have a lot of time, I'm going to report on some of the work that my predecessor and some of my current colleagues have been working on. I had nothing to do with this, so I'm not going to claim in any way any ownership of it. And so all the mistakes are mine, and all the applaud for the work goes to others. Is to actually be able to use something like the data that we're collecting to be able to do a paper of this nature, which I think is extremely important. So here you can see we had 7,690 patients completed EPIC 26 data, and at the time we had 10,924 in the registry, people who'd completed the EPIC 26. So what we're able to do was actually map across geography and equally looking at their index of relative social advantage and disadvantage, which is a surrogate marker for, and it correlates reasonably well, gives you a score, the ERSAD score, which we got from the Australian Census. Now, in effect, it just allows you to then generate heat maps. And all these papers are, this is actually open source, so you can get access to it, and I'll leave all the references. But it's kind of interesting to see how it maps. And as you'd imagine, that there's better outcomes in the metropolitan centres, and as you radiate out into lower socioeconomic areas, it gets worse. And that possibly isn't surprising, but it's good to have the data for that. I work at the Northern Hospital as well as the Director of Research, which is 30 kilometres to the north of Melbourne, and it's outer metropolitan. It's got a large population of culturally and linguistically diverse people, and also is a lower socioeconomic status. So again, we can see there that there are issues about care and provision, and there's a lot of work now that should be done to try and explore that and to try and address it. And that's why doing these kinds of pieces of work is very, very important. And, you know, perhaps the other paper here that, or part of the paper that I think is important, I haven't got time to go through all of the data here, but just to sort of orient you a little bit, if you look at the second graph down, so there's 5 from the top. You can look at watchful waiting. Active surveillance is the benchmark of 0, and you can see that obviously we have worse outcomes or reported outcomes for people who have advanced disease and who are undergoing treatment in the third bar. But then you can look at the ERSAD and you can see that, yes, if there are people in the lower quartiles of ERSAD, that they have worse reported outcomes. So this is an important association. And now we have to do the work to try and understand it and do something about it. We also have the True North Global Registry, which brings together 13 international registries, which is extremely important. And I'll talk very briefly about that. But again, we only take a PROM at 12 months at the moment for the PCOR across Australia, with the exception of New Zealand that does some baseline. We really would like to get baseline PROMs and then do the 12 and 24 months. And I know each of the various jurisdictions have been looking at the opportunities to do that. And one of the great things with the electronic systems is that we have an opportunity to be able to capture that electronically. And I know Belinda made a mention saying that telephone, got better recalls. Well, we're sort of finding a bit of a hybrid of that. We're finding a lot of people like filling in the EPROM, but we do have to remind them over the phone, and that actually is something that we haven't been able to quite break down. But one of the big projects we'll be doing in Australia in the next 12 months will be really seeking to get the baseline PROMs in play. And part of the reason for that is that it's actually very difficult to know longitudinally what's happening if you don't have the baseline. So sure, you've got the 12-month and it gives you some information about the status of people and their unmet needs and their situation, but it'd be good to get a bit of a trajectory as to where they started and then where they ended up. So the more time points we have, the better. So again, another paper that my predecessor Nathan Papa led together with Jeremy Miller, who's a radiation oncologist, was just looking at the manner in which we collect them and showing that email reminders do actually have an important utility. And we actually demonstrated this, that doing the emails increase the response rate. Now, if you actually look at our response rates, they're pretty good. They're right up at the 87%, which I think is extraordinary when you think about it. And we're getting a relatively good kick for an inexpensive strategy to increase that rate further. So, we do find that it is labor intensive to do this work, and we have a call center, and we have a number of data collectors and various people all around the states and territories. So this isn't cheap, but it is very effective. I'm just going to contrast that a little bit with a comment, and I'll sort of close up by saying, when we look across internationally, and I'm just picking on a Swedish group, they looked at their 20-year journey, and they've been working at a national level. It's hard to find a lot of countries that have actually got national registries. I spoke to the Italians recently, and they don't have a national registry of any description. The United States doesn't, the Canadians don't, the UK doesn't really. It's sort of a bit fragmented. The Germans are probably the most efficient at this. In fact, at the TNGR level, they have put in the most patients. They put in over 50,000 of the 100,000 in the TNGR, which actually makes it the next largest is the Michigan group, which have put in over 35,000. And so you can see cumulatively the other countries really haven't put in very many. It actually makes it somewhat difficult to do analysis across the countries with the disparities in numbers. But nevertheless, this is a group that have done PROMs on paper questionnaire, but now they're doing them all electronically. They've also been able to generate dashboards. Haven't got time to really go into great detail. Wonderful thing about the Swedes is that they've provided it all in English as well. So that's rather wonderful that they've done that. They have started all the dashboarding, and that's an area that we'd like to do in PCOR, to provide dashboards to our doctors and to the health services so that we've got real-time data influencing care. But they don't use the same PROM tool, and they actually have something that is a little bit more complicated, and I obviously haven't got time to go through it all. I'm just flashing this up on the screen so you get an idea that there's quite a few more elements than the short form, the EPIC 26. It's not long, but at the same time, it's not short. And so one of the things that I'll end there just to say is that they actually had some conclusions about what they were doing in this, where they suggested that, in fact, the ICHOMS international data set wasn't the best one that they wanted to use, and they didn't feel that it was as representative, and there is some disagreement amongst the various countries as to which is the best PROM tool to use. It is cultural. We, in some preliminary work, which is a bit too unprepared yet to share with you because it hasn't been published and it's still being reanalyzed. We have seen some differences between some of the countries, such as Spain, Italy, Czech Republic, Germany, and Australia. And some of that, we do wonder whether it's cultural, whether people are prepared to say things about their sexual function, depending on where they live and the cultural sensitivities around that. We know that that will differ also depending on who's asking. And one of the pieces of information that I didn't share with you just then, but is in the paper that was published about the use of telephone tool versus EPROM, is that we do see differences in some of the sexual function reporting between the telephone and the EPROM, which suggests that people may be less inclined to give certain types of answers to someone over the phone. And we know that speaking to a person can influence outcomes versus filling it in. One of the interesting things about that was we're also finding that for some of the EPROMs, partners were filling it in and reporting sexual function. So that was kind of interesting too, about making sure that we're actually getting it filled in by the right person and that the data isn't being somehow skewed by someone else's perspective. So there is an important question there, as whether we should be asking things from carers, support people as well in that. Anyway, I'll leave it there. That's just a whistle-stop tour through some of the things we're doing, and it just leaves us time for questions.
Yeah, great. Thanks, Nick. If anyone has any questions, please pop them in the Q&A or chat and we can get to them. Nick, both you and Belinda had really high rates in responses to your PROM questionnaires. Is there a standard? Like, is this higher than what you would expect, or?
It seems to be, doesn't it? It's you know, when we do questionnaires, we often find that they're fairly poor. You know, we're lucky if we get 20 or 30% response rates. People think that that's fantastic. And I think we have a highly motivated group. And I think that there has been a transition. I was talking with a colleague earlier today in a lung cancer context, and we were saying they extensively use patient experience measures around the hospital. And it's all about the timing, and it's about the relationship that you have. So we do tend to find that, particularly in these areas, that it's the timing and the integration with the health service that supports the high levels of response. So if it's seen to be something that's coming from the health service and it's related to the clinical care, people are more likely to say, I'll fill it in. And obviously, if it's relatively short and it's not as troublesome to do it, they'll do it as well.
Yeah, great. Yeah, I also thought it was interesting about the difference in sexual function responses over the phone versus online. I imagine traditionally PROMs would have been collected in person as well. So those sort of questions would have been, is there a reluctance even more so when it's face-to-face, or are you completely past the face-to-face collection?
It's very varied. I mean, obviously it's with the pandemic, it's pushed us more towards electronic means to do these things, and people fill them in. I guess it's a question as well, do people have time to think about it and say, well, where am I on this scale? And I know that a lot of people are now starting to use more dynamic forms of doing this, where people can register and provide more up-to-date information in real time by giving scores on an almost daily basis. They're using devices as well to track and do things in other ways. So it's interesting, because I spoke to a colleague of mine who used to run the telephone line, and she said a lot of the men were very forthcoming about their sexual function.
Maybe they don't get to talk about it with anyone else.
Yeah. Almost at the point of bragging about it in some instances. But you know, that was kind of good. I think the other thing is, it's about the timing. We provide feedback on the PROMs to the doctors if we get outliers. So if we see an outlier in a patient and it's directly related to a practitioner, because we have identifiable data, we'll tell that practitioner and say, by the way, Mr. Jones, you might want to chase that up.
Yeah.
And the doctors have been saying to us, actually the baseline would be more useful, because we kind of, and even 6 months and 12 months, because then we've got a sense of, you'd be helping us to understand what's going on for our patients.
Yeah.
And I think there is going to be that transition. I think we're going to, and that's what we certainly want to explore at PCOR, is the ability to start using those tools in more real time.
Yeah. Okay, great. Well, it doesn't look like we've got any questions, so we might just head off or get to the next bit, which we're almost finished. So thank you very much for that, Nick.
Nice.
Next week, we're going to be hearing from Mel Tinsley from the Agency for Clinical Innovation and Kimberly Williamson from the Cancer Institute New South Wales. And they're going to be talking about developing culturally appropriate PRMs for Aboriginal and Torres Strait Islander communities. And Kim Morey from the Wardley Paringa Aboriginal Health Unit theme at SAMRI, she's going to be chairing that one. So I'm going to be signing off now. Thank you everyone for tuning in. Thank you, Nick, and thank you to Belinda as well. See you later.
Bye.